So keep it. Okay, it really is going to help you a lot. Okay. All right, so all of this stuff here is important when it comes to the aseptic technique. Mask and bonnet. Look what it says. Both you, the nurse, and the patient, it's in bold print, have to wear a mask and a hair cover when we do dressing changes. Unless there's some other hospital protocol, which there would be for a PICC line, you change the dressing every 48 hours. If you can see where it says confirm placement with X-ray, you're going to highlight that. You're going to highlight scrub the hub for 15 seconds. And chlorhexidine is the last word in that sentence was scrub the hub with 15 seconds. You guys all have chlorhexidine on your handout? Because I had changed the literature a little bit. Okay. All right, so chlorhexidine is what we're going to use with this. Now, PICC line. Now the RNs can insert these, as you may or may not know. You can see the confirm with X-ray. For delegation purposes, you don't need to worry yet, but you will later about what the LPN can do. How long are PICC lines good for? 1 whole year. Highlight it. You can use them for all infusions. We love them, of course. And you don't have to change this dressing, which is occlusive, except for every 7 days. So you've got to know that. And then the last thing on that list that you have to remember is the non-tunneled. Let me make sure you understand what non-tunneled and tunneled means. Generally speaking, a tunneled central line is surgically placed. A regular old-fashioned central line, like your TPN patient, your PICC lines, your triple lumens, you can see the incision on the outside of the patient. Those are non-tunneled. They are at increased risk for bloodstream infections, hospital-acquired bloodstream infections. The tunneled catheters are not as high risk for bloodstream infections. And if you look at the bottom of your page, you've got the portacath, which is called a metaport. That metaport and that Hickman, both of those are surgically implanted. So it's really tiny in the second line, but I want you to highlight the word tunneled. And I want you to highlight that you need an Uber non-coring needle for access. No dressing change needed. No exit site, no incision. You don't even see it. And of course, we flush it with saline only once a month. So all of that is written for you. Okay. Next on the lineup is the top of the page. The top of the page distinguishes between phlebitis, infiltration, extravasation. So at the top of your page, everything is written. Just a little bit more concentration is on the board for what you personally have to know. Okay? So let's deal with phlebitis. Now, if you've been with me long enough, you know that I write straw for a lot of things to make your life easier. So let's just remind ourselves what the hell is straw. What is the S? Swelling. What is the T? Tender. What is the R? Red. What is the A? Nothing or something. We'll figure it out in a minute. But what is the W? Warm. For some things, I use the A. For some things, I don't. So just for the record, when it comes to a DVT, a deep vein thrombosis, I use the same mnemonic: swelling, tenderness, redness, warmth, and then I use the A and put anticoagulants, right? Okay. Infection. swelling, tenderness, redness, and warmth. Antibiotics. You don't understand it yet, nor do you need to, but if I wanted to go a little bit further and talk about the patient with, some kind of problem in their intermittent claudication, swelling in their legs, we call it PVD, peripheral vascular disease. They too may have some swelling, tenderness, redness, and warmth, and we may give them an antiplatelet aggregate, but that's for 2501. Just know straw is going to apply to a lot of things, infection, phlebitis. Now, the problem is you cannot think of this as an infection. It's not yet. Phlebitis is not an infection. So you do not need antibiotics yet, if you play your cards right. So even though it's swelling, tenderness, redness, and warmth, we don't need to treat it with anybody's antibiotics if we what? Take it out. So let's take it out. Every single one of these, you're going to take it out. But you're going to take it out, and you will not believe how many nurses get this wrong in the real world. You're going to see them when you get out of here. They don't know it's warm compresses. They want to do cool. So what I always tell you in this class is if you don't know the rationale, then you can't defend it. Just like with the patient, if you don't tell them why, they won't comply. You just sound like a bitch. She told me don't eat this, don't eat that, don't go here, don't exercise there, don't smoke this, don't smoke that, don't drink this, don't... Shut up. Why? Okay, so here we go. Why can't we do cool compresses here? Here's why. When you have phlebitis, you have an inflammation of the vein. The blood is palpable cord, kind of trying to almost clot up a little bit. It can be ropey. It's already sluggish, which means slowly moving through that inflamed vein. You get red streaks because it's so slow moving and it's trying to stick to the wall of this inflamed vein. And of course, if you were crazy and you did cool compresses, you would cause what we call vasoconstriction, and you'd give even less area for this slow blood to move through. And that's when you cause inflammation to become a clot. Thrombophlebitis means clot in the vein. That's what thrombo means, clot in the vein, because you did something silly, like put cool compresses on this patient. If we give them warm compresses, we're going to vasodilate and encourage circulation to the tissue, blood moving all the way through, and healing. So you don't want to get this wrong. People get it wrong every day. It's annoying. Like, oh my God, who's teaching these babies? Okay? So that's that. Okay? Now, the opposite. Hello. The opposite is infiltration. This is cool to touch when you find it in your patient. This one was warm to touch. This is cool. Keep your warms together. Keep your cools together. Cool skin gets cool compresses still. Take the daggone thing out. You'll be sorry. This is, by the way, this is not defensible in court if you don't take it out. You can defend yourself. They don't know what your problem is. Why wouldn't you take it out, nurse? That's the standard of care. So take it out. Elevate. You elevate both of them. You elevate both of them to enhance venous return. Ain't that right? Okay. Now, what does it look like to you? If you picture some meat in the market, which fat is all the way through it, like marbling fat all the way through pink meat, that's what it looks like. That's called mottled and blanching. So you see the skin looks like, oh, like a little design. Okay. Cottage cheese colored or something weird. Mottled, blanching skin, fluid leaking all around the site, cool to touch. It definitely has become dislodged. And I want to draw your attention to what I wrote, just so you follow along here. You can see the phlebitis. You can see some other things that I wrote, such as a break in aseptic technique or failure to anchor the IV. Highlight that. Failure to anchor the IV. You gave some irritating drugs and you didn't cause any kind of extravasation, but you still gave a little bit of irritating drugs. Then we have the whole straw thing going on at the end of the paragraph. Okay, so that's fine. But above it, you have some other little details that I wrote at the top. Just remember that the bag and the tubing get changed every 24 hours. The entire IV itself, the peripheral IV, should be taken out and a new one put in. Generally, most places will say 72. There's a few that say 96. Did your school teach one or the other, or did they kind of roll with both? Both. Good. So they did teach both. It depends on your hospital, right? But when you agree that after 96 hours you're out of control if you still have an IV from the, okay, so you know. All right, so infection is just so real in these patients. Okay, now, so we did our infiltration. Infiltration has a bold word right next to it. What is it? Extravasation. It's right here. Because if infiltration of a vesicant drug occurs, now we don't have a simple infiltration. So if your patient got infiltrated with Vanco, oh, no. We now have extravasation. We now have extravasation. Okay? All right. Now, so here we go. Under infiltration, trauma to tissue can be really extravasation of a vesicant drug leaking around the vessel. Now, why did that happen? Improper placement. Let me give you a good example of what you don't want to do. You get a patient who's elderly, and they come in and they're frail, and you try to put an 18 gauge in their vein. You're probably going to get some infiltration. You need to consider a 20 gauge. The higher the number, the smaller the needle. And for something like a TB test, hint, hint, you need a 27 gauge. Okay, so we're talking ion injections or sub-Q or intradermal or whatever. So 27 gauge for something like a TB intradermal test or babies. We need a 22 or a 20 with the elderly. We need an 18 anytime we plan on giving blood. So 18 gauge. A 20 is okay in the elderly, but I wouldn't try to put an 18 in a 92-year-old lady. I would try, even if she needed blood, I'd be trying to get a 20 in her. So the higher the number, the teeny tinier is the needle, whether it's an IV or an IM or sub-Q or whatever the hell it's called. Okay. Now, so those are some things that can make your patient have infiltration. You tried to put this like big whopping needle in this teeny tiny vein. It's not going to work. Okay, so improper placement, using the wrong vein, putting it in the antecubital site also, just in the back of your mind. Rapid infusion rate, you're doing too much. That's what I call that. You are trying to flood the gates and you blew the vein and you're splashing all over the vein, essentially. Puncture the vessel during insertion. So while you're putting in the IV at a 15-degree angle, while you're putting in the IV at a 15-degree angle, some people that don't get how to do IVs are using a 45-degree angle, at which point you stab through both sides of the damn thing. So you're coming at the vein like this, like an airplane, sliding in. Not this. That's 90, right? 90 would be straight down. People do this though, and it's just as bad, because if you think of the vein, you went through the top and then you came off the bottom a little bit. Now the fluid's going to leak out that bottom. So you're just like a plane, 15-degree angle. Okay? All right. Then you have your extravasation, and you already know. This is some crazy shit here. So what do you got to know? I keep saying it over and over again. pH less than 5, greater than 9. What is that called? An osmolarity or concentration greater than 500. What was normal? Less than 300. Here are some drugs you want to conscientiously think, I might need a central line for these. Vanco we give in a peripheral line all the time, but we're very, very, very cognizant of the fact that we could cause extravasation. We're watching the line. We've got a decent sized needle. We hope and pray we got a great vein. We keep the patient hydrated because dehydrated patients have flat veins. Okay, so you got your Vanco, you got your potassium chloride, your Dilantin, your multivitamin. Believe it or not, multivitamin can be very vesicant to the vein. Irritating, burning, all the nonsense. Okay? Consider central line. A midline would be lovely for the Vanco, but you could never do it for the rest of this, because midlines still have to follow the same rules as peripheral. But it does allow for dilution of the solution. So I'll say that again about the midline. It allows for dilution of the solution. And it says that a little bit right there under it. It says provides better hemodilution. Do you guys see that? I actually wrote that for midline, underneath the midline. It provides for better hemodilution. Does everybody see that? Is that a yes or a no? Yes? Okay. All right, baby. So that's it. This is your fluids. That's the end of that.